Good afternoon, everyone, and welcome to Medical Grand Rounds. Just a reminder before we get started that I will ask you to please enter your questions in the chat at the end of the presentation, and please answer a brief survey that will be made available to you right after the presentation. This will let us know that you were present today. Before we start, I'd like to make a brief land acknowledgement. McGill University is on land which has served as a site of meeting and exchange amongst indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. We acknowledge and thank the diverse indigenous peoples whose presence marks this territory on which peoples of today of the world now gather. Thank you very much for our speaker today is coming to us courtesy of the Division of Radiation Oncology, and I'd like to call on Dr. Tarek Ejal from the Division of Radiation Oncology to please present our speaker. Tarek?
Thank you very much, Nadia. It's a pleasure today to introduce my colleague, Dr. George Shenouda, for Grand Rounds. Dr. Shenouda is a radiation oncologist at the MUHC, an associate professor in the Department of Oncology at McGill University. Originally from Egypt, he completed his medical studies there before moving to Canada. He then trained at McGill University, where he obtained a PhD in cancer immunology before pursuing a residency in radiation oncology, followed by a fellowship in pathology research. He then joined the Department of Radiation Oncology at McGill, with a cross-appointment in otorhinolaryngology in view of his important collaboration with the ENT specialists. So in addition to head and neck oncology, Dr. Shenouda is involved in research and treatment of CNS tumor, as well as benign disease. He's also very committed to medical education, having received the prize of Most Outstanding Teacher in Radiation Oncology for 3 consecutive years, the faculty honor list for educational excellence in 2006, and having been selected as one of the inaugural laureates to the Academy of Exemplary Physicians. Dr. Shenouda will present today about the role of radiation in benign diseases. Without further ado, Dr. Shenouda.
Thank you, Dr. Hijal, for your kind introduction, and it gives me great pleasure to be here today and to be invited to the Medical Grand Rounds to present the role of radiotherapy in the management of benign disease. We are all familiar with the role of radiotherapy in malignant conditions, neoplasm, and we rarely see the application of radiotherapy in benign disease. So it is an important issue that we need to clarify and have some idea how it is happening in our practice. The content of the presentation will be some basic principles about radiobiology, the mechanism of action, the clinical radiotherapy and its application in benign disease, the radiation-induced second malignancy, which is an important part of the talk, as this is a question that always comes to the mind when we use radiotherapy in the management, both in malignant as well as benign, but more so in benign disease. And then we'll make some conclusion at the end. So part 1 would be the basic principle of radiation radiotherapy, which is mainly related to some experimental and laboratory presentation of radiotherapy and how we quantify it. Like I said, radiotherapy is mainly used in the management of malignant neoplasm. And as we know, malignant neoplasm is a leading cause of death in Canada over many years. And the use of radiotherapy is estimated to be about 50% of patients during their course of the disease will require to have radiation treatment, either as a curative or as palliative intent treatment. The frequency of patients that we see in practice with radiation treatment is important because that will present to different medical and surgical disciplines with issues that were related to their treatment, and therefore some basic information about radiation and its mechanism of action will be important to grasp before we go into more clinical application. As any therapeutic agent that we use, whether it's a medical radiotherapy or surgery, there is always a therapeutic range and a ratio of what we want to achieve cure or treatment of the disease we are dealing with versus the consequences or the side effects or the treatment-related toxicity that we can provoke in the patient. And there is the typical curve, the S-shaped curve, where when we increase the dose of radiation here on the x-axis, which is the dose in centigrade or rad, versus the effect of radiation treatment with or without chemotherapy. Definitely with chemotherapy, the effect is more intense and more steep. However, there is a level where we increase the dose of radiation treatment and we have a minimal increase in response, but a significant increase in toxicity. So that's the whole point, that more is not always better, and more is associated with significant toxicity. The dose at which this curve shifts is what we call the radiation tolerance of the organ, and it is organ specific. Each tissue has its own way to respond to treatment. Now we are going to look at some basic work in the lab to quantify the radiation treatment and to see how it is working. So in the Petri dish, we can plate some cancer cells, different numbers, and expose them to different doses of radiation treatment, and then plate them for about 2 weeks in order for them to form colonies. And then we look at each colony, at each Petri dish, and count the number of colonies and create a surviving curve. The surviving curves are plotted. The result is expressed in a semi-logarithmic or logarithmic phase, which definitely shows clearly that when we increase the dose of radiation treatment, we increase the cell killing, or the survival fraction decreases significantly. And this is the basic principle of dose relationship and its effect on cell survival curve. This is in the lab. And when we look at how does radiotherapy or ionizing radiation cause this cell killing, it's mainly through cytotoxicity. Ionizing radiation most of the time is using X-rays, and the X-ray is simply an electromagnetic wave carrying energy, and when it's interact with the electron of an atom, it gives it energy and ejects it from its orbit. And therefore we call it ionizing. There will be a negative charge, and the atom is left with a net positive charge. So the electron with the energy that it acquired will move and cause ionization of water and cause DNA damage with the peroxide and hydroxy radicals. The other pathway is that the electron will go directly to the DNA and cause damage there without going through the step of hydrogen peroxide and hydroxy radicals. Most of the biological effect of radiation is caused by the mechanism of water-mediated or peroxide-mediated cytotoxicity. Only 20% is caused by direct effect of the electron on the DNA. Bottom line is that DNA is damaged, and when the DNA is damaged, there will be chromosomal damage, and this will lead to the impact on cell survival. One of the mechanisms is apoptosis, which is the active cell death when the cell receives a lethal effect and it cannot repair it. It will go into the process of apoptosis. This is like one of the mechanisms of action of radiotherapy. The second one is reproductive death. You remember when I said that the DNA is damaged, and when it's damaged, when it comes to go through the cell cycle into mitosis, then it is unable to do that, and this will lead to the cell not being able to divide. And in other terms, there is no reproduction, and the cell does not multiply and does not divide. The third, which is a rare mechanism of action, is immediate necrosis, and this is only limited to the lymphocytes and the spermatocele, where an impact is seen immediately on the cell without having to go through apoptosis or reproductive death. But this is uncommon. And another mechanism of action is cellular senescence, radiation-induced cellular senescence. And this is when the cell becomes stable and unable to repair the damage, but also unable to go into cell cycle. So this is a kind of replicative damage, and it leads to a various effect of impact on the normal tissues and the malignant tissue. The malignant tissue will not be able to divide and multiply, but will remain there, and the normal cells will also not disappear. However, they are unable to regenerate, and that's important for the long-term complication that we see after radiation treatment. So that's what I said, is that in the one hand, the cancer cells will stop proliferation, but the normal tissues will also be affected and will be unable to repair the damage or to regenerate in the future. And this is certain pathways that are affected with ionizing radiation on the tumor cells and the normal tissues. And this is important because when we irradiate a malignant neoplasm, we are by definition irradiating unavoidably normal cells and normal tissues in the vicinity. So this is important to realize, that we are not only targeting the cancer cells, but we are also causing changes in normal tissues in the neighborhood of the cancer tissues. Another mechanism of action, which is the effect of radiation treatment on sites far away from the site where the irradiation is given. It's called Abscopal effect, and it is mainly activation of the immune system. The antigen, after large doses of radiation treatment, is released into the circulation, and from there, immune mechanisms are activated and affect malignant neoplasm metastases far away from the site of the original application of the radiation treatment. Although rare, but it happens, and we sometimes see very dramatic response to localized radiation treatment in a systemic way, where lung metastases disappear, and the response is really dramatic when it happens. Unfortunately, it's not very common, but has been a part of the treatment that sometimes is given for patients with malignant melanoma, renal cell carcinoma, where this effect are most frequently observed. Now we are going to look at the clinical radiotherapy and how it is delivered. Mainly is radiation treatment through a fractionated course of radiation treatment. You will always hear the patient is going to get 4 or 5 weeks of radiation treatment. Every day the patient comes Monday to Friday, get a dose of radiation treatment, and then continue for the duration of treatment, depending on the total dose. What happened in this fractionation is that the normal tissues and the malignant tissues respond to this fractionation. The fractionation will allow the normal tissue to repair the damage so that they are not totally destroyed with the radiation treatment, but be able to repair after the treatment is completed. And they have an advantage over the malignant cells because they have a better repair of damage. The malignant cell is chaotic in its repair of the damage and usually does not repair as good as the normal tissues. Redistribution, where the cell cycle is arrested in a phase of the cell cycle that is mostly sensitive to radiation treatment in the G1M interface. Repopulation of the normal tissues, again, it is important to realize that the cells can be depleted, but the stem cells of the tissue will reapply their genetic capability of regenerating and will cause restitution of the normal anatomy and function. Reoxygenation occurs because oxygen, like when you saw the interaction of the electron with water, it requires oxygen to proceed into peroxide and hydroxy radical, and this will intensify the effect of radiation treatment. Now we look at the effect of fractionation. When we give radiation treatment, we look at the tumor, the normal tissues, both of them. One is early responding acute tissues like skin and intestinal lining, or long-term late complication tissues like the spinal cord or the bone. And when we give the radiation treatment in multiple small fractions, we get rid of the cancer, we reduce the normal tissue, so that is acute side effects of treatment, but then it will come the repopulation because we have not exceeded the capacity of the cell to repair the damage. And that's also seen on the long term. The tissue will not be compromised in the future and the function will be maintained, given that we have given small dose per fraction. On the other hand, if the dose of fraction is given in a small but in a large doses, but infrequently, so it can be the same total dose, but given in a larger dose per fraction and fewer number of treatment, the effect is similar on the tumor, more intense on the early responding tissues that come early and more severe, but on the long-term complication that will be loss of the parenchymal function of the tissues, and that will be depleted of the normal function on the long term. And this is what we avoid because that will be the one that can kill the patient or can cause significant morbidity affecting the quality of life of the patient. So we deliver radiation treatment through external beam, which is mainly through a linear accelerator. The patient lies on a table and the gantry of the machine has a 330-degree rotation. The table has 360 rotation, and the treatment is delivered from different angles to focus always on the area containing the tumor. And we can deliver photons, X-rays or gamma rays, and particles, mainly electrons. Neutrons and protons are used in certain centers, but in our center, we don't have protons radiotherapy. The other way of delivering radiation treatment is when there is contact between the radioactive sources and the patient, either in the tissues itself or in a cavity. And the two examples that I chose to show here, one is for cervical cancer irradiation, where the radioactive sources are brought in close contact with the tissues bearing the tumor and delivering very high dose in the surrounding area. Here it's an example of prostate cancer irradiation with needles given local for the prostate. This technique allows a high dose of radiation treatment to be delivered to a very small volume with a rapid fall off of the dose to protect normal tissue, which are, like in this case, bladder, the rectum, and you can avoid significant toxicity. The role of radiotherapy in the treatment of benign disease is always associated with the concern of radiation-induced malignancy. And since the day where it was discovered, X-rays have been used for multiple indications because it has an anti-inflammatory effect, and people have discovered that it can be useful in many conditions. However, This was met with some discouragement, and reality showed that there is short-term and long-term complication, and we have to be very careful in the application of radiation treatment to benign conditions because the implications are significant, and it takes time for the response to be seen, given that we are using benign situations where the patient life expectancy is quite long, and most of the time they are usually young patients. And these two factors I will going to explain in the next few slides. So here there is a table which summarizes the use of radiation treatment in benign condition, like you have multiple organs and different conditions, and I will focus on those treatments that I am familiar with and I'm using in my practice, mainly in Dupuytren's and Leathers disease, as well as the orbit and the eye. So I will focus on this, but there are indication for the use in head and neck when patient has like cyluria from neurological diseases where they cannot swallow saliva, in situation when there is a patient with heterotropic bone formation to use it in the immediate heterotropic, in the immediate post-operative period to avoid the complication of heterotropic bone formation, coronary artery stenosis, and cardiac arrhythmia. These are areas that are being used, and I'm not going to discuss them because this in itself is another area of expertise that I personally don't have. So Dupuytren's contracture or disease is a chronic and long-term proliferative disease of the Palmar fascia and the Palmar aponeurosis, and it is a gradual onset and progressive course. Usually the disease starts and the patient has it for 5, 10, 15 years, and then at one point the functional deformity arises. Usually it's after the age of 50, and the worldwide its prevalence is about 8%, and in North America it's about 2 to 3% of the population would have Dupuytren's disease. Male are more affected, and usually the disease is progressive, and the course is indolent, and at one point it can become rapidly progressive, and that's where the importance of long-term follow-up of the patient. The genetic predisposition has been studied in multiple studies, and there were some genomic regions that were associated with Dupuytren's, and the patient can also have other proliferative disorders, mainly plantar fibromatosis, Leatherhose disease, or Peyronie's disease in 8% of the cases. It can be associated with diabetes mellitus, with liver disease, medication or epilepsy, liver disease and alcohol consumption, and exposure to vibration, especially young people using machine in construction, where they are exposed to frequent repeated trauma from vibration of the equipment they are using. The clinical evolution is a proliferative, progressive involvement of the palmar fascia, and then the fascia start to create nodules, which then become fixed and the periosteum of the bones and lead to the characteristic deformity of the hands at the metacarpophalangeal and the proximal interphalangeal joints. The deformity causes flexion, deformity, and extension deficit of the fingers, which can impact significantly the patient functionality and use of their hands. There are three phases of Dupuytren's, which mainly the proliferative phase when there is nodule formation. There is the involution or fibrotic phase where the involution of the myoblasts increase and there is formation of bundles and cords in the palm of the hand. And then the residual fibrosis when it continues to progress and cause the progression deformity, the flexion deformity. And usually it's about 50% of the patient that will progress within 5 years of the onset of their disease. The staging is one of Tubiana's modification, where stage 0 is mainly fibrosis with no flexion deformity. The N is when there is starting of nodules, but no flexion deformity. And then you see the difference, the different stages, 1, 2, 3, and 4. And you see the progressive flexion deformity at the metacarpopharyngeal and then the interpharyngeal joint. And definitely you can appreciate how this deformity can be a handicap for the patient to function normally. There are surgical approaches which are standard of care now, and this is by all means considered to be the first step and the most appropriate one, which is surgical fasciectomy, when there is like an open surgery to remove part of the fascia. Needle aponeurectomy, which is less invasive, but can through small incision, it can lead to freeing the flexion deformities, or collagenase injection in the local areas of involvement. It has very good response, and usually the results are great. But when we see the patient and their follow-up for more than a few years, we see that about 25 to 50% of them would require further surgery because of the recurrence of their flexion deformity. So it's an effective treatment. However, the rate of recurrence is not negligible, and the patient requires further intervention afterwards. Radiotherapy has been used, and for long term, mainly in Europe. In North America, it has been, there was a reluctancy to use it, or the medical opinion was mainly for a surgical approach. There was a study done and published in 2001 for radiotherapy, but it was radiotherapy comparing two different modalities of fractionation schedule, and it lacks the comparison to a control arm, and that's one of the deficiencies of this study. However, it has been done and published, and I want to share it with you. So there were group A, where they were given 10 daily fraction of 3 gray per fraction in 2 series of 5 fractions separated by 6 to 8 weeks. And the other group was given 7 daily fraction without interruption, like over a week and a half. And they compared the result. Toxicity was similar, and the response was evaluated by objective and subjective evaluation, and the follow-up was at least 1 year after the treatment. So the results showed that there is no major difference in the response rate or the toxicity between the two arms. And there were a rate of regression of the lesion in half of the patients, 56 and 53%. And there were remained stable in 37 to 38%. However, there was 7 to 10% who progressed. And that's what we see in practice, and that's my own personal finding, that about 70 to 80% of patients are stable or improved, but about 20% of the patients have a progression of the disease and require further management. What is important is that further management, whether it's surgery, will not be complicated by the fact that the patient received radiation treatment. So that's what one point that we need to emphasize to the patient, that should they need further surgery, there was no problem having the surgery after radiation without significant increase of side effects. So the lack of randomized controlled study for Dupuytren's and its general use in a lot of centers have created a certain need internationally to proceed to a randomized study to be able to answer the role of radiotherapy in a controlled way, so that we can have a clear answer to our patient and to know how to use radiation in an optimal way. And this study is an international study called DEPART, and it aims at randomizing patient to two arms of treatment versus observation for patient in prevention, meaning before any surgery is done, the patient is given radiation or observation to prevent further progression of the disease in an adjuvant session in group 2, 3, and 4, that patient after surgery will have radiation or observation to see if really radiation treatment reduce the chance of recurrence. This is an international study, and unfortunately, we try to join the study, but there is conflict in the rules and the contract between our institution and Quebec and Canada versus the sponsor of the study, and we are not able to proceed to join this international study. Unfortunate situation. Now we are going to move into another site that I am also treating, and this is mainly in the orbit. And the orbit, the main treatment that we are all familiar with, or most frequently used, is the use of radiation treatment for orbital thyroid orbitopathy. And this is like an autoimmune process following Graves' disease, and it is mainly affecting the retrobulbar tissues with inflammation and swelling, leading to protrusion of the eye, proptosis, and all the impact on the muscles and the double visions and the compression of the optic nerve. So this is mainly one of the indications where we use radiation treatment. And there has been a randomized clinical trial published in Lancet in 2000. It's a small study, however, it showed some differences which are important to recognize. There were 30 patients in each arm. One was given radiation treatment, dose of 20 gray in 10 fractions, and the other one was given observation or sham irradiation for the same number of fractions, but no radiation was delivered. So there was success of the treatment in 60% of the patients who received radiation treatment, and it was mainly noticed in improving the ocular mobility, and the double vision. And also after radiation treatment, the field of binocular vision was enlarged in 11 of 17 patients, and this was compared to sham radiation when only 2 have improvements. So on this basis, we know where to use radiation treatment and where we can have an impact, mainly for patients who failed high doses intravenous steroids, resistant to steroid treatment, and patient can benefit, especially if there is compression of the optic nerve and compromise to the vision. Radiotherapy can be used, and we work with the ophthalmology team to see the best way we can use radiation treatment in this context. This is an example of dose distribution for patients with thyroid orbitopathy. You can see that the dose of radiation treatment is nicely tailored to the orbits and avoiding the anterior compartments and the rest of the brain and the optic enhancement usually is well tolerated. The patients have 10 treatment on daily basis for 2 weeks, and the long-term side effects are quite limited to cataract, and we don't see optic neuropathy or neuritis following these doses of radiation treatment. And another application is a cavernous hemangioma. This is another example of a cavernous hemangioma in the right eye, and you can see the volume of radiation treatment is very contouring the lesion and avoiding irradiation of the neighboring structures. So this is a kind of indication where there is compression of the optic nerve and failure the disease progresses and there is compromise. So radiation treatment is one way to avoid progression of the disease. And another example, optic nerve meningioma, where we use a stereotactic technique. We're using 7 stereotactic field, focusing all on the optic nerve and avoiding treatment to surrounding structure. Dose of 50 gray in 30 fraction is usually very well tolerated. There are some incidents of radiation-induced optic neuritis and some retinopathy. However, the patient can keep the eye without having to go through significant morbidity from surgical intervention. I'm going to give an example of treatment that we deliver using saber knife. It's not a benign condition, but I just want to give an example of a treatment that can be delivered with this technology, which is available at our center. I chose to show you a case of choroidal melanoma, which is not benign disease. However, it is an example of how focused we can deliver radiation treatment in a very small area without having to irradiate large volumes. And this is 45 beams of radiation, all focusing on this small lesion in the back of the eye. And we use eye fixation so we can make sure that the eye does not move during the treatment. And this is like given under supervision with technology that can detect eye movement and interrupt the treatment and modify it according to the patient position. So this is not benign condition, but it's an application that can be used also for such a disease. So we come to an important part of the discussion, which is the impact of radiation treatment and the fear of causing second malignancy. So we know that the patients who survive cancer and long-term survivor are at high risk of developing second malignancies. The second malignancies can be from a genetic predisposition, can be related to the treatment that the patient receives, as well as their daily normal habits. And I will go through that in the next few slides. Radiotherapy can contribute about 5% of the total second malignancy seen in patients who are exposed to radiation treatment. And the incidence of second malignancy has been noticed to increase over the decades from 75 to 79% to almost 20% in 2005 to 2009, the National Cancer Institute. The pathogenesis of radiation-induced malignancy depends on the environmental and lifestyle factor of the patient. We can see that the risk factor of lung cancer is related to smoking, especially in patients who had been exposed to radiation treatment like Hodgkin lymphoma. The lung has received a dose of radiation treatment, and the incidence of second malignancy is much higher in those patients who continue to smoke versus those patients who do not smoke. In head and neck malignancy, if the patient does not smoke after treatment, the cumulative incidence is about 8% at 5 years to develop a second malignancy. However, if this patient continue to smoke, the cumulative incidence is 40%, dramatic increase, and that's one part of the counseling that we need to explain to the patient, that the risk of malignancy increases significantly with smoking. The patient who have received radiation treatment for breast cancer, when they have smoking, the risk is increased and is mostly restricted almost to those who are smokers. So the genetic susceptibility has been studied, and there is the genome-wide association studies showed about many factors, many risk factors, and genomic areas of pleomorphism located mainly on the 6th chromosome. Most common genetic abnormalities associated with acute myeloid leukemia and myelodysplastic syndromes, as well as there is genetic susceptibility related to how we metabolize the chemotherapeutic agent, and we can deal with the repair gene of each individual, which definitely is an important factor regulating the incidence and presence of second malignancies. So radiotherapy is one of the factors, and the radiation treatment caused single and double strand breaks of the chromosome, leading to malignant transformation and genetic mutation. Radiation can also affect the repair mechanism and the ataxia telangiectasia gene, and increase the susceptibility to malignancy. And the largest study that has been published is related to the atomic bomb survivor in Japan, and they showed that there is increased second malignancies when the dose of radiation is above 2.5 gray total body. Again, not all the body organs are affected equally, or they are susceptible equally to radiation-induced malignancy, and the thyroid gland is one of the most susceptible one. However, like bone and muscles are less susceptible, and this is another area of research that needs to be addressed, why this is happening this way. So again, chemotherapy has also an important impact on the development of second malignancies. Most of them will be related to leukemia and myelodysplastic syndrome. Certain malignancy of the bladder with cyclophosphamide related to exposure to metabolites is also well known and is site-specific. It's important to realize that knowing all this fact about radiation and all treatment, malignant disease treatment, we need to look at what is the strategy for and recommendation for screening of patients who have been exposed to radiation treatment, especially those who had also radiation and chemo in childhood. And the recommendation is to start radiation screening at a younger age and use multiple modalities of evaluation, let's say for breast cancer, MRI, ultrasound, and mammography, and do it more frequently annually instead of the recommendation for older patients and those who have not been exposed to radiation treatment. So what are the interventions that we can do to reduce malignancy from our treatment? In patients with Hodgkin disease, we used to use large volume radiation treatment, mental and para-aortic and spleen radiation. Now we try to use a response adapted approach to treatment, where we can use limited radiation fields and sometimes omitting radiation completely if the patient has an excellent response to systemic treatment. Patients are at risk for breast cancer after chest wall irradiation at younger age. And some publication were suggesting to use bilateral prophylactic mastectomy to reduce the incidence of breast cancer in these patients, especially if they have a positive family history of breast cancer. So we conclude that yes, radiation treatment has its role in the use in benign condition and has an acceptable therapeutic strategy, and we need to use radiation treatment in a multidisciplinary approach where all the specialties put together a plan of action and explain to the patient the risk that they have with each approach, and get the patient the best recommendation for treatment for the condition they have. And we look forward in the future to have randomized clinical trials that we can help us to pinpoint and clarify the use of the radiation treatment in benign disease. It is difficult to perform such studies because when we give radiation treatment versus observation, the patient usually are reluctant to accept such studies because of the nature of observation, but we need to give time to the patient to understand the difficulty with the decision to be made and the importance of doing clinical trials for their situation. I'd like to acknowledge Ms. Bachu for her contribution in the preparation of this presentation.
Thank you very much, Dr. Shenouda.
I will be ready for questions.
Thank you very much for this comprehensive review on radiation, from the radiobiology to more the clinical aspects in benign diseases. Before handing off the mic to Dr. Janetti, I'd have to say that when we compare our center, and you might want to chime in too, when we compare our center to other centers across the province, the country, or even the continent, do you believe that we are seeing a more important or less important number of patients with benign diseases? Because from what I've seen, the practice varies a lot from center to center.
Yeah, I think we are seeing, Tariq, a lot of referral for benign disease, mainly Dupuytren's. Recently, over the course of the last 2 to 3 years, there is always a patient who are referred. And this is like kind of awareness in the surgical colleagues, in hand surgery colleagues who realize that the surgical intervention does not always lead to what we expect, especially for the incidence of recurrence. And the international kind of knowledge now that radiation treatment can have a positive impact. Not all the patients that we see are getting treated. So the patient comes, and when I see that the patient has a stable disease, has not progressed, I always give a time for 3 to 6 months or even a year to learn about the tempo of the disease. Is it progressive, or it is a stable disease that does not require intervention, at least not for now? And this is something.
Hello, Mr. Daponti.
I'm sorry?
Bonjour, ici c'est Dr. Faria, radiothérapie. Vous avez terminé la radiothérapie le mois de mars. Je vous appelle savoir comment allez-vous après la radiothérapie.
Sorry about that. I think that's somebody who's not muted. We'll let you continue what you were saying. Yes.
Okay. So the patient, when they are referred, and we tend to make sure that when we say yes, there is like a role for radiotherapy that is given after a period of observation, and not to jump immediately. The patient who had surgery, however, a different story. When they come with a surgery that has been performed, we need to treat them within a short period of time because the process of fibrosis and contracture can happen very rapidly. And to benefit from it, it has to be done within a short period of time.
Thank you.
Fantastic. Thank you so much. Tarek, I don't know if you want to make another comment. I just have a quick question for you, for both of you, actually. There's questions in the chat, but what percentage of your cases, just grosso, are like malignant versus benign in radiation therapy? Are we talking about 5% sort of, or are we talking?
Yeah, less than 5% of our caseload is
so we have
benign.
Quite a few questions in the chat. How does our radiation therapy compare to excision in peripheral subcutaneous schwannoma?
Yeah, that's a new kind of intervention. It's mainly for localized disease, where it can be injected locally. And there is a phase 2b study that was published in the Lancet and showing promising results. However, the impact on the flexion deformity and the more advanced disease is to be seen in the near future. But it's a new approach using the anti-TNF injection. Yes.
Okay. A comment from David Rosenblatt. Years ago, it was common to treat skin hemangiomas in infants and young children with radiation, whereas today we tend to observe these to see whether they regress. Are there long-term follow-ups of this cohort?
I have personally not been involved in, but usually when there is observation, we try to avoid giving radiation early on. I'm not aware of a clear answer to the question here.
There's a comment about keloid as well in some children. I don't know if there's if you have any comments about that.
Yes, there are certain situations where the keloid treatment can be important because of the consequence of cosmetic impact on the patient, even at young age, when they have on the face and the ear and the exposed part, when it causes them a lot of significant withdrawal, social withdrawal, and affect their long-term sociability because of the obvious lesion they have. However, it needs to be discouraged as much as possible, given the young age, the benign condition, and the high risk of malignancy in this group of patients. Yes, it is to be avoided as much as possible.
Okay. There's another question here. Can you treat CTS and pulmonary fibrosis with radiotherapy? I'm not sure. Do you know what CTS means?
No, if you can explain.
Yeah, can you please explain what CTS is? And what about pulmonary fibrosis?
I'm not aware. I'm not aware, and it can be a possibility, but unfortunately, I don't have an answer for this question.
Carpal tunnel syndrome, maybe?
Oh, yeah, carpal tunnel syndrome.
Carpal tunnel syndrome, we have been mainly like surgical treatment for the carpal tunnel. I have not treated any, and I don't know whether it's useful to treat carpal tunnel with radiation treatment.
So just a question, sort of a overall question. If you look at the MUHC, what does one do with respect to survivorship and following some of these young patients, in particular, who've received extensive radiation therapy? Who looks at that? I assume in radiation therapy you don't do these long-term kind of follow-ups, or do you follow your patients sort of yearly? I see Tarek nodding. Can you comment on that, please?
Yes, for sure. And we have Dr. Caroline Freeman with the hematologist, pediatric hematologist and oncologist, who have a long-term follow-up of survivors for years and years and years. And I don't know if Caroline, you are able to make any comment if you are on.
Yeah, I'm still here. I mean, I think it's important to know that Radiotherapy could be pretty useful in a lot of different situations, but the question is whether it's better than surgery, which it may not be. For example, for subcutaneous neurofibromas, I don't think it's ever going to be better than surgery for that. And then in other situations, in a young person, you want to avoid radiotherapy. So we don't use it for hemangiomas anymore. There are lots of circumstances where we don't use it. And then others, it's a very useful treatment that we do use. And I mentioned two in the chat. One is sialorrhea. We have an experience with treating sialorrhea in patients with neurological and other conditions, even young children. And we also have a fairly large experience, actually, with pigmented villonodular synovitis. So, it's not as common to use radiotherapy for benign disease as it was in the past, but we do it. It's very hard to follow these patients. To address the actual question, which is about follow-up, for patients treated for benign disease like keloids, it's very hard to follow these patients. You might get them to come back once or twice, and some of them may be followed by the plastic surgeons, but the reality is most of them are not followed for the 20 or 30 or 40 years it takes to develop a secondary malignancy. For patients who are given therapeutic radiation for malignancy, yes, they're followed. I mean, we want to follow them, we need to follow them. And there are structured guidelines that we follow to evaluate patients over long term. And it's not just for secondary malignancies, but as you know, it's also for cardiovascular and other problems. So yes, there's a long-term follow-up clinic, and yes, we follow patients long-term, but it's very hard for patients with benign disease, particularly young ones.
Fantastic. Do you have a registry with all these patients that you are following?
We know who they are. Yes.
Fantastic. Well, this has really been a very informative, very comprehensive lecture. Thank you so much to Dr. Shenouda and for actually the RADONC team for all your participation in today's medical grand rounds. And it's coming up on the hour, so we're going to close the presentation, close the rounds. Appreciate everyone's participation today. Please answer the brief survey that will be sent to you shortly. And Dr. Shenouda, really thank you so much. Congratulations on all the great work you're doing for the department and the division of radiation oncology. And thank you for sharing that with us today. I wish everyone a great afternoon.
Thank you very much for inviting me, and I really appreciate being here today in this grand rounds. It's an honor for me. Thank you so much.
Thank you so much.